while assessing the ECG of a person with a pacemaker, two important aspects to be thought of are the pacing function of the pacemaker and the sensing function. Pacing function is simple to understand. The function of pacemaker to give regular electrical signals to pace the heart. Sensing function is there in all pacemakers now, which inhibits the pacemaker when a spontaneous impulse is sensed from the heart. If the lead is in the atrium, it will sense the atrium, and if the lead is in the ventricle, it will sense the ventricle. So both these functions have to be assessed when you see an ECG. Beyond that, there are special algorithms of pacing which can also be assessed, provided you know the programmed parameters of the pacemaker. Some parameters may be different in different pacemakers. So what you think that is abnormal for one pacemaker function may be normal for another pacing algorithm. This is an ECG in a person who has been implanted with a pacemaker. We do not know whether it is temporary pacing or permanent pacing. But there are some features which would suggest. You look at the regular ECG pattern. You can see Q and T inversion in lead 3, T inversion in lead 2, and T inversion in AVF with a small Q wave, suggesting an inferior wall infarction. There is ST depression in V5 and V6 with T inversion. So you know that this is a person with coronary artery disease, myocardial infarction, probably recent. There is some ST depression seen here, but there is not much of an ST elevation. So an infralateral infarction. And look at the PR interval. The PR interval is significantly prolonged. So we can presume that this is a person with acute infralateral myocardial infarction who has undergone pacing, temporary pacing for complete heart block, and it has recovered. The infarction has also partially recovered, and the conduction also has been better because it's only first degree AV block. Earlier it would have been either advanced AV block or complete heart block. Otherwise nobody will put a temporary pacemaker. Now comes the interesting part in the ECG. You look at this pacing spike. It has occurred after a short interval. This is the regular RR interval, and this is a premature pacing spike. That means the sensing function of the pacemaker is not okay. And you can also see the second P wave here. This is the first P wave before the QRS, and there is probably another P wave here. That's why I have marked the interval. I have taken the PP interval from other regions and marked it here so that you know where the next P is supposed to come. This is a deformity on the ascending limb of the T wave of the paced QRS complex. You can compare with this. There is not much of deformity of this ascending limb, or better this. So in all probability, the pacing, the natural sinus P wave has occurred in the ST segment of the paced QRS complex. Then there is a pause. This can be explained because this P wave did not get conducted. Why? The QRS has occurred because of the ventricular pacing. So it will get conducted back into the AV node also, and when it reaches the AV node, it will cause interference with the antegrade conduction of this P wave, something we call as interference AV dissociation. So that is probably why the QRS is not there. Another possible explanation is ventricular refractory period, but with this PR interval, if this P wave gets conducted, it should come as a QRS here. That has not occurred. So this is most probably interference, this AV dissociation due to the retrograde conduction of the QRS. Then the pause is there. then sinus cycle, you are seeing the regular sinus beat with a prolonged PR interval. Then there is another beat here. This is also a paced QRS complex. This interval is less than the regular sinus interval. So this is also probably indicating a sensing function abnormality. Here it is again one more sensing function abnormality, very premature pacing spike has come, and here you do not find a QRS complex. Why? You might be tempted to think that it is pacing failure. No. Look at this QRS. This spike has occurred within the QT interval of the previous spontaneous QRS. That means it has occurred during the ventricular refractory period. So you don't expect ventricular capture in the ventricular refractory period if a pacing spike occurs there. So this is only sensing failure, not capture failure or failure of pacing function. Then you have another pacing spike here and a QRS complex with T wave. So overall it shows that pacemaker sensing is abnormal. Then we do not know the set rate of the pacing function, so you cannot say much more on that. But when you see in the setting of inferior wall infarction, probably a temporary pacing and a pacing sensing failure, the first possibility which you should think of is displacement of the lead. You know, the temporary pacing lead is just placed in the right ventricular apex, and when the person moves or coughs or something like that, the lead can get displaced and move into the right ventricular outflow tract where it will be floating. It may not be touching the myocardium. In that case, there could be sensing function abnormality as well as pacing function abnormality. But here we have definite evidence of sensing function abnormality or pacemaker sensing failure. We will not be very sure about associated pacing function abnormality, and we are in fact seeing some paced QRS complexes. When the lead is floating, it can touch the myocardium or not touch the myocardium, and even without touching it, if it is near, the voltage given to the signal may be high enough to cause capture. Usually temporary pacemakers are set at much higher pacing voltage than permanent pacemakers because you know that there is chance of lead displacement and we want to ensure capture even if there is mild lead displacement.